as if 6 minutes wasn't short enough, we're going to somehow divide this topic up between two of us and talk about meaningful use audits. And so if you were to poll practice managers or CFOs of hospitals and say, what's the favorite thing that President Obama has done for you, their answer might be the stimulus bill that enacted meaningful use incentive payments. Because bottom lines for hospitals and physician practices have benefited immensely from payments that began in 2011 as a result of the stimulus bill, if their organizations really engaged in the meaningful use of electronic health records. That is to say, they really incorporated the use of those records into the care of their patients. Since 2011 through today, approximately $15 billion with a B worth of incentive payments have been paid out to providers for that meaningful use. And alarmingly, there has been relatively no audit activity of that until recently. Just starting last year, that the CMS, really at the behest of congressional leaders, OIG, GA, the Government Accounting Office, said, you know, there needs to be some more accountability to these payments, especially when you consider the fact that to qualify for those payments, all these organizations had to do was to fill out an attestation to say, yes, we are meaningfully using electronic health records in the care of our patients. And so what we're starting to see is clients that are starting to receive these audit inquiries and go through this process that CMS has created for auditing the receipt of those meaningful use payments. And I think the challenge that we're finding is that, and I find this somewhat ironic, is that while encouraged to use records electronically, the audit defense to that is to generate potentially reams of paper about how you've been using electronic health records. For instance, one of the things that you have to demonstrate is that your technology is a certified EHR technology. Your proof of that is a screenshot printed off that shows that your technology is, in fact, certified, and that's the one that you're using. Another one that's really challenging, and so there's a whole bunch of measures and criteria that you have to meet, and a lot of them are numerator-denominator type analyses. So for instance, one of the criteria you have to meet is that 30% of your patients are getting their medication orders done through a computerized physician or medication order. Well, to generate proof of your compliance with that, you have to prove both the numerator, the 30%, and the denominator, which is your entire patient population. If you further complicate that with what we're starting very early signs to see on the Medicaid level, because so far this audit activity has really emanated out of the Medicare side. Medicaid is not accepting, this is a pilot audit, so we're not sure this is going to really stick, but they're not accepting these dashboard reports that your EHR technology can generate. Instead, they're requiring you to run lists and lists and lists of all your prescription orders. And so it can be a very onerous activity, and one that I think more and more providers are going to see here going forward, because I'm going to leave you with this thought. CMS has contracted with a contractor, Figliosi and Company. They've developed this sort of automated audit protocol, and the intelligence that I've heard is that CMS is targeting to get to a point where 1 in 5 recipients of those meaningful use payments are going to be audited. They want to get to that level. And so if you take into account, for instance, that could be on an individual physician basis, you know, within a large practice, you could have multiple physicians within that practice getting audited. So I'll turn it over to Claire with some practical tips and pointers to supplement that.
Thanks, Jim. Yeah, I just was going to add a few points to Jim's comments about how we've been involved in assisting clients in this area. So we have had the opportunity to work on some audit projects as that whole initiative that Jim mentioned, the contractor audits have started. I think that's been kind of a wake-up call for people, because the original stage 1 attestations, that may have been some time ago, and the audit issue was not really the focus at that time. So we've had chances to do a couple of things. One would be a post-attestation audit, where we've gone in and looked at the type of documentation that a hospital had in place to support or demonstrate that they met the meaningful use requirements when they attested. And that's kind of, you know, pulling together information and beefing up what they may have already had. Another type of project that we've been involved in is a pre-attestation audit, and that's for folks who haven't actually pushed the button that, you know, I comply. It's all an online attestation. And that's actually a really nice opportunity opportunity. I don't know how many folks there might be out there still who are in that situation, but that same opportunity will come up when they raise the bar and folks are looking at attesting for what's called stage 2, which is going to have some more challenging and different requirements to some degree. So in those projects, what we've been able to do is, in the stage 1, for example, your attestation period, meaning you have to show you comply during this period, is a 90-day window. So people have been able to kind of start looking at what they're meeting and building their documentation and sort of working out bugs and questions about that, and then deciding, okay, we're really ready to attest, and when we get to that point, we can start our 90-day period, which is, it's 90 days out of a year. And in some of those projects, we've helped people just with certain questions that have come up, and I wanted to mention a couple of those that were kind of interesting. For example, one is, well, what happens if we change EHR systems midstream? So what if we change EHR vendors altogether, or we do a significant upgrade or something after we've already attested or during the attestation period? And so those are kind of interesting questions, and those can be worked out. I mean, basically, if it's after attestation, you're fine. You can keep your meaningful use dollars, and otherwise, you can sort of combine the two systems' numbers. There is an obligation to notify CMS if you learn at some point that you did not meet the requirements. So you attested, yes, we meet them, and then you discover something later, maybe on a self-audit. And there will be take-backs on audits. I mean, they will be taking back some money, and there will be self-reporting. So there was a case that made the news. I'm sure anybody in this area who's interested in this area heard about it, that HMA, a very large system, self-reported and turned back to CMS $31 million and took 11 hospitals from their system out of the program because they did a self-audit. I think this probably came up in due diligence. They've been going through a sale. And so they discovered that they didn't actually meet the requirements, and they turned back the money. So we'll probably see some of that. And another type of context in which meaningful use comes up, which this kind of points up, is transactions. So it's become a due diligence issue, and checking to see whether a hospital you're acquiring or affiliating with or whatnot actually meets these requirements. But also if you're doing any kind of corporate restructuring. So we had an interesting project that came to my desk where somebody was doing a corporate conversion, and in the course of doing that, they were going to be disallowed from collecting all the meaningful use dollars for all of their physicians. And it happened to be, get the call, 2 days before the deadline for the year ended, meaning if they didn't sort this out in 2 days with Medicare, they were going to give up on all that money. And we were able to essentially restructure their conversion so that they avoided that problem. And it had to do with their tax ID number associated with the assignment of those dollars from physicians to that entity. So just to keep that in your mind, that if you're doing transactions and restructures, that you need to think about meaningful use.